My name is Pedro Panares, and I'm going to start reading our case study about cardiovascular system. I'm going to read the patient presentation and history and her past medical history. Our patient is a 45-year-old female, Maria Lopez, is brought to the emergency department by her family after experiencing dyspnea, shortness of breath, swelling in her legs and ankles, peripheral edema, and persistent fatigue. Maria is a school teacher and had been feeling increasingly tired over the past 2 weeks, which she initially attributed to her demanding schedule. However, the swelling and difficult breathing worsened over the weekend. Maria denies any angina pectoris, chest pain, but mentions waking up gasping for air at night, paroxysmal nocturnal dyspnea. Her past medical history includes an untreated hypertension, hyperlipidemia, and a family history of congestive heart failure, CHF. Her father passed away in his late 50s due to complications from heart failure. Maria's sedentary lifestyle and high sodium diet have contributed to her cardiovascular risk factors. She denies any previous diagnosis of diabetes mellitus, smoking, or alcohol consumption.
Hello, my name is Jose Caballero, and I'm going to be reading the second part of our case study, which is the current problem and lab test. Maria is experiencing symptoms constant with fluid overload, including perineural anemia, pulmonary congestion, and difficulty breathing. Her fatigue and walking episodes of paroxysmal nocturnal dyspnea suggest worsened cardiac decomposition. Labs and tests. The medical team performs a physical examination, noting elevated jugular venous pressure of the JVP of bacterial putting anemia in her lower extremities. As culturization realizes cracking sounds in the lungs, which are rales, and abnormal heart sound, which is the S3 gallop. Both indicate the left-sided heart failure.
Hello, my name is Lorenzo Vaccari, and I'm gonna read the third part of the case. The following tests are ordered by the first one is the electrocardiogram to evaluate the cardiac rhythm and rule out arrhythmias or evidence of mitochondrial infraction. And this electrocardiogram shows sign of left ventricular hypertrophy and ischemic changes. The second one is the chest X-ray, it indicates an enlarged heart and pulmonary edema. The third one is the echocardiogram that confirms reduced ejection fraction, indicating systolic heart failure. The left ventricular function is impaired. The fourth one is the blood test, and it states elevated brain natriuretic peptide levels are consistent with heart failure. A basic metabolic panel reveals hyponatremia, elevated creatinine, and early sign of renal insufficiency, suggesting cardiorenal syndrome due to poor cardiac output. The fifth one is the coronary angiography, performed to rule out significant coronary artery disease as a contributing factor. The angiogram shows no major blockage.
Hello, my name is Gerardo Garcia, and I will be doing the diagnosis and prognosis part. Maria is diagnosed with congestive heart failure with reduced ejection fraction, secondary to long-standing hypertension and likely exacerbated by dietary habits and inactivity. Early-stage kidney damage is also noted. Treatment includes three parts: medication, ACE inhibitory to reduce afterload and improve cardiac output, beta blockers to decrease myocardial oxygen demand, diuretics to manage fluid overload and improve symptoms of pulmonary edema and febrile edema, spironolactone to prevent further fluid retention and reduce mortality in CHF. 2. Lifestyle modifications, sodium restriction, initiation of structured exercise program, and regulatory monitoring of blood pressure and lipid profiles. 3. Follow-up testing, serial echocardiograms to monitor heart function, and renal testing to assess the impact of treatment on kidney health. Prognosis depends on Maria's adherence to treatment and lifestyle changes. With proper management, the progression of heart failure can be slowed and the quality of life significantly improved for Maria's life.